Health has asked us to be focusing on. And we are just sorting out, this is a warm-up for all the speakers and how we're going to handle panel presentations. So thank you for your patience as we are sorting this out. But I'm really, really happy to be here, and thank all of you to be here in person and also virtually. And thank our host and Mwanda for hosting this meeting. I'm very excited to be co-moderating this session with Dr. Neil Squires. I'm apparently the good cop. He's the bad cop who's going to make sure every speaker stays on time, because we have many of you. And really, this is an incredible session, I think, for sharing knowledge and expertise and our collective experiences, and sort of asking us the question of how do we build public health system resiliency and strengthen delivery of the essential public health functions, something that all of us continue to do in our respective national public health institutes. And I think, as the initial panel has indicated, this is quite a special moment as we're coming through the pandemic of COVID-19, but with many more health challenges, including numerous emergencies, climate-related events that are challenging all of our communities and our societies. So I think public health is increasingly finding ourselves in the middle of I think providing our input into very complex emergencies and health events. And as we prepare for future emergency and other ongoing health challenges that affect our communities, we need to foster and support our public health workforce, because people are our greatest assets. So we have to invest in strengthening the workforce and find ways to also build surge capacity networks. So I really look forward to our discussion today, and we'll consider, as we consider our own individual realities as well as the global collaborative approaches. And today we're going to have an incredible set of panelists who's going to take us through a number of, I think, stage-setting presentations from the WHO, but also regional and country experiences. But we are expecting to reserve about 30 minutes at the end so that all of you could have a chance to share a Q&A session, ask our panelists questions, but also maybe share a little bit about your experience as you face with developing the workforce and EPHIs. And I think also, we're asking the question of how you're working with schools of public health, for example. So think about that as we're going through the panel discussion. And our first panelist is Dr. Sahel Sakat from the WHO. He's going to speak about setting out the process of defining the essential public health functions and reviewing public health skills and competency to deliver these functions. Thank you, Dr. Sahel.
8 minutes now, thank you.
Let me check whether the slides. Jessica, can you? Yeah. Still not there. Okay. So, thank you, Professor Tam, and thanks, Neil. So I think the presentation that I'm going to is very much part of the collaboration that we fostered with IANPHI. So this is the report that the Secretariat, I think, shared with you all. And thanks to the discussions we had in Paris meeting, again sponsored by Public Health Agency Canada and Santé Publique, again part of the MOU that we signed between our DG, Dr. Tedros and Duncan. So I think this is again reinforcing what Professor Tham has been reinforcing. So I'm not going to go into detail, but as you could see, all of these challenges and stressors that you have, so we need to be very pragmatic here. We cannot come up with a separate system to tackle all of these challenges. So the role of public health is completely indispensable here for 3 reasons. One, public health is all about intersectorality. Second is positioning public health in frontline health service allow and a small event to be tackled fast before it could become a big event. Third is a strong public health in primary care level can also reduce the pressure on secondary and tertiary care. So colleagues, there are many colleagues from Europe. Europe has been championing, at least from a perception-wise, on public health. And this is the allocation of GDP according to different European countries. Again, no criticism here, but this is the candid reflection. There's a spike in GDP allocation during COVID-19, but overall, as you could see in terms of the distribution, majority of the health expenditure are still on secondary hospital-centric service. So the public health constitute only 0.6% of GDP. We do not have a comparable data for other WHO regions, but we can expect similar statistics. So at the same time, I think we are all public health communities. We are passionate about public health. One of the limitations that we had when we looked at from in terms of the evidence is that there is no authoritative understanding what is the scope of public health, what the public health in operation and service should look like. Unfortunately, that has been escaped. It was identified during Ebola as a gap. It was identified again during COVID-19. So colleagues, this is again, I think, the report that you had seen for the first time. We as a WHO, we looked at all of the list of public health functions from WHO regions as well as from other authoritative bodies like US CDC, World Bank, etc. And we identified that there are more commonality between the list of functions than a specificity that are present between the regions. So what we as a WHO came across is that for the first time, 4 service delivery related functions and 8 enabling functions, and they're all interdependent. And if you look at the list, the protection aspects, promotion aspect, prevention aspect, as well as there's a clear prominence for public health emergency management. But the key aspect is that is the interdependence between service delivery for public health as well as what enabled them. If you look at the wordings carefully, I think there's a lot of thinking based on the global experience is, for example, public health leadership, multi-sectoral planning and financing, as well as the intersectoral aspects came up very, very strongly. Similarly, also the public health surveillance and monitoring. I think the beauty here is that it can bring all aspects of public health in one framing. Second is that some of the blind spots that we often have, that we have seen in the last crisis during COVID, during Ebola, this approach can allow you to address those blind spots so that you can come up with a comprehensive approach to public health. Again, is the country to contextualize, country to prioritize, but all we are saying as a WHO, it has to be integrated, it has to be a proportionate focus based on the population health needs. So colleagues, not to go into the detail, there is one question about this topic. How does it relate with IHR core capacities? How does it relate with EDRM? How does it relate with health systems framework? How does it relate with PSC operational framework? So simply what we are going to say is that this public health function as an approach to strengthen capacity for health system is a complementary one. But it allows health system to reinforce public health. It provide co-benefits for all other framework that we have. At the same time, it developed the understanding of all of the other particular efforts for that embracing public health. So colleagues, what we had done, again, thanks to IANPHI colleagues and institutions, so we just did not come up with the 12 functions. There has been meticulous, detailed exercise building on the global evidence. We unpacked each of the functions into sub-functions, and from that, we came up with bundle of what should constitute as a public health services and enabling systems input. And we adjusted them by looking at the duplication, complementarity that are present. For the first time, as a WHO, in an objective way, we defined that bundle of public health services which cut across all aspects of public health, from promotion to prevention to protection, in an objective way. So this is captured in the report that you have seen from the Secretariat. So colleagues, the other thing is that again, we have been mindful that there are so many assessments that you have under IHR, under universal health coverage. We as a WHO do not want to introduce another assessment to our member state. But what we came up with a simple metrics that anybody can apply in your country context. One, what is your public health consideration in your national policy and planning? What is your public health consideration in infrastructure, in service delivery platform, and coordination, learning, and M&E, so that you can come up with a proper baseline for public health in your country to inform policy and planning. So this approach is a smart one, building on the current assessment, building on your policy and planning documents and your infrastructure and service, so that you can inform the right policy and planning for improvement, including the role of National Public Health Institute. So very, very briefly, colleagues, it's not that we are just coming up with a normative way. I think with our regional office and country office, there are a number of countries are applying this approach so that it can strengthen the role of Public Health Institute, it can strengthen the National Public Health. So there are some countries, we have details in the report that you have, maybe some examples that are placed on the slides, but I'm not going to go into the detail. And the second one, I think my colleague Kasumi is going to elaborate another extension of this work targeting 100+ countries. Again, thanks to many of the institutions who are here about the public health roadmap to deliver public health functions. So I end just giving 4 questions. I think it came out also from the minister, is that we cannot expect a different result in the future pandemic if we continue to do the business as we have been doing. Something needed to be changed. At the same time, even in European context, the countries that have been championing public health, that model unfortunately did not work even in Europe. That model did not work even in North American countries. So 4 questions that I want to finish before. One is, what role that National Public Health Institute can provide for a comprehensive approach to public health based on population health needs, burden of current disease, and future burden of disease that you have. Second is, what are the enablers and challenges that you always face to operationalize public health in a more integrated way? Third one, so the list that we came up, the package that we came up for service, as well as enabling systems input, how that can help you to deliver your work. And then the final one, thanks to Duncan for your leadership with Professor Tam and many other champions for public health. And we also have our WHO country representative, and next year we are meeting in Mozambique, what type of partnership that we can develop so that there can be a step change. There can be a step change that we can report to Mozambique as well as in upcoming events. Thank you.
Thank you
And
very
brilliantly
much.
to time as well.
Thank you very much, Dr. Sahel. And our next speaker is Dr. Kasum Diallo, who is from the WHO. He is actually going to present the WHO roadmap to build the public health emergency workforce and its components, and the importance of partnerships, which has already been emphasized. Over to you.
Thank you very much. I would like first to thank the organizers for inviting us, and I am talking here on behalf of Dr. Jim Campbell, Director of Health Workforce Department. We developed together with, can I have the next slide, please? With leading public health organizations, a roadmap for strengthening national capacity to implement essential public health functions as described by Sohail. And this roadmap aims at, can I have the slides? This roadmap aims at really strengthening the national capacity, which means that it's about what would be the workforce that is needed to implement the essential public health functions and to face any threat. And that is critical because when we talk about roadmap, we have to talk about strengthening a way to strengthen the workforce at national level. And which workforce are we talking about? Sorry, the slides are not coming back. I don't know who is managing that. Okay. Anyway, I'll be talking and then for the sake of time. When we talk about public health and emergency workforce, who are we talking about? Are we talking only about epidemiologists? Are we talking only about water, sanitation, hygiene? Are we talking about district managers? Who are we talking about? Those people should be the people who are implementing the essential public health functions at all levels. And in that, it cannot be one single occupation. When we hear countries talking about public health, we hear them talking about MPH, those field epidemiologists, etc. Those are critical people in that field, but they cannot do the work alone. We have to understand that we have to bring community health workers. We have to bring doctors and nurses at primary health care level. We have to bring other occupations that are outside of the health sector. Water, sanitation, hygiene, road traffic, air pollution. All those are doing public health on a daily basis. It is important that we approach this from a comprehensive perspective, looking at both those who are core public health workers, like epidemiologists and the others, those who are core health workers, like doctors, nurses, and midwives, and etc., who are doing part of their time public health work, and those who are outside of the health sector, which is in primary, those who are doing water, sanitation, hygiene, and all the others. Having a comprehensive approach will help us identify which functions are well performed and which functions are not well performed. If you take one function like surveillance, you see a range of occupations doing surveillance. It is not only one occupation that is doing surveillance in a country. It's a range of occupations. And for us, what we want is that the surveillance function is implemented. We have to make sure that those functions, those occupations that are doing surveillance have the right training, the right competencies. And that's why the roadmap is building on 3 action areas. One, of course, is the essential public health functions as developed by Sohail. The second is the competency-based education, because it is critical. And the third is the mapping and measurement of the occupations, which occupation we have to talk about. And that will be critical. The second question that I've been asked is, what would be the implementation of the roadmap? And for that, we have done piloting in a number of countries. We have a series of results based on the tools that have been developed. We have developed a package that build on the 3 action areas, the competency-based education, the mapping and measurement of the functions, and then the essential public health functions as just described. And we have a package now that is ready to be shared with countries so that countries can implement, and we are happy to support the countries in this implementation. And now the third question is, what is the role of the National Public Health Institutes? And this is critical. First, we know that, and everyone knows that, these kind of threats cannot be addressed or cannot be tackled by one institution alone at national level. We have to look at national partnership. We have to make sure that the different entities at national level speak to each other. And we have done some work in implementing the mapping and measurement of health occupation in piloting in 7 countries. There have been some critical public health functions or institutions that did not talk to each other during the COVID pandemic. And we realize that this has been a mistake. So this multi-sectoral governance approach to these things is critical, and it is important. Now, in terms of developing, making sure that countries, making sure that the competencies are well understood and implemented, making sure that the multi-sectoral approach, multi-sectoral governance is adopted for that is critical, and that is also one of the potential role of the public health functions. So rolling out the roadmap as developed, but also making sure that at country level, they have the capacity of bringing the key stakeholders together around the table and implementing together. It is not one entity conceptualize everything and ask the others to help. It is co-conceptualization, co-implementation, and co-supporting each other at national level. And that is critical. Sorry, the slide are just coming, but for the sake of time, I am going to stop here. Thank you very much.
Thank you.
And just a quick apology. So the slides will be made available, but a warning to others, just in case. We did say be prepared to extemporize, and that was a brilliant example of being able to think on your feet without the slides. So well done.
Thank you so much. And that was a really great overview. I think the key message about the interdependencies and of the essential public health functions. And so I think that's a good segue. You mentioned competencies. It's a good segue to our next speaker, Dr. Laura Magana, who's actually online, and on the role of the schools of public health in working with NPHIs to train the public health workforce of the future. And she will highlight the importance of competency-based experiential learning and the needs for schools to work with the National Public Health Institutes to build our future workforce.
Now, Laura's at a conference in Morocco, so I had to record this. So I think we should have the recording, hopefully. Yeah. Oh,
Yeah, I'm
sound's
the
not,
President and CEO of ASPPH, and I'm here today as President of the Global Network of Academic Public Health. I apologize for not being in person with you, but I wish you great success in the meeting. Today, I want to talk about the role of schools and programs of public health in working with the National Public Health Institutes to train the public health workforce of the future. The Global Network for Academic Public Health is an alliance of 7 regional associations that represent schools and programs of public health around the world. Our vision is to enhance academic public health worldwide through mutual learning and collaborations between academic public health institutions in order to improve and protect the health of people and the planet. We see value in multicultural, multinational, and multilateral engagements and partnerships, the same as IANPHI. Our global network of academic public health is really honored to be a partner to IANPHI. Our missions and visions are strongly aligned, both focusing on improving and protecting public health globally, with a focus on strengthening the current and future public health workforce. IANPHI and the Global Network have both been heavily involved in the critical work of developing the WHO roadmap that Dr. Diallo just presented and are committed to ensuring its implementation. The challenges in global public health are multifaceted, underscoring the urgent need for a resilient and well-prepared workforce. The acknowledged shortage and weakness within the public health workforce are compounded by persistent underinvestment, deployment complexities, and global migration trends, exacerbating shortages on a global scale. Many nations grapple with the absence of robust information systems, leading to labor market failures. Simultaneously, health emergencies, demographic shifts, gender inequality, and substantial underinvestment collectively emphasize the imperative for comprehensive reforms and strategic interventions in the global public health landscape. We also strongly believe that to improve health and well-being outcomes for everyone, everywhere, we need to ensure universal availability, accessibility, acceptability, coverage, and quality of a diverse and competent workforce. The schools and programs around the world are working intensively in 2 areas: supporting the current workforce and training the new generation of health professionals. In the area of supporting the current workforce, we very quickly learned that COVID exposed the dramatic shortage of health professionals needed to effectively respond to a pandemic, and also highlighted the insufficient funding to support the work of those we do have. The current workforce is overburdened, underfunded, and sometimes even under attack. from the communities that they are committed to helping. We are advocating for transformations of our health professionals' educational programs. The pandemic has demonstrated the need to develop competencies beyond the traditional public health education domains to be most effective in responding to crises. Skills in leadership and communication and advocacy are essential to help communities understand threats and make healthy choices. Technological competencies and understanding of key global health concepts like One Health and climate change are fundamental to operating in a global world. Health equity and social justice must be at the core of our mission. And installing a culture of lifelong learning will ensure our workforce stays up to date with best practices. We're also reaching out to other professions beyond the health system. Decision makers from government and across all fields need to establish at least basic knowledge in public health in order to understand and best serve their communities. Using data and scientific evidence to support decision-making is fundamental to making the best decisions to their communities, and communication and consensus building are essential to be able to respond effectively and efficiently in the event of a crisis. Workers now experience at least 12 job changes by the time they retire and stay in the workforce at historical high rates into their late 60s and 70s. Through the lenses of human longevity, work becomes inextricably tied to education. The needs of the population are evolving all the time. New threats to the health of populations and the planet are constantly evolving. Our profession is a living system where we need to constantly be uplifting our competencies to keep up with new viruses, threats, and innovations to protect the health and well-being of our populations. With this new approach, an emphasis on learning to live a balanced, healthy, rewarding, and happy life is critical to prevent mental health issues from all our professions. And we need to keep them and to preserve them with a sense of purpose, belonging, and well-being. This is particularly important with all the health professionals that tend to be stressed, overworked, and dealing with other people's challenges. So the schools of public health and the National Institute of Public Health in each country need to strengthen their relationships in order to tackle these and many other issues related to really securing a capable workforce. Periodic returns to learning are the new normal. There will need to be more on and off ramps to long life learning for the public health workforce. So we'll need to harness the power of education, gaining what we need and seamlessly entering the workforce highway. So we have work to do together, because working together, the National Institutes of Public Health and the schools of public health can identify training gaps, develop and deliver educational pathways that will provide updated competencies and allow public health professionals to meet the evolving health needs of populations they serve. Using innovative approaches, we can design educational experiences that ensure the public health workforce is prepared to address current and future public issues. So thank you again for this participation, and I really hope you have great discussion in how to strengthen our common agenda. Thank you so much.
Thank you. So I think that presentation also challenges to think about our public health systems as a learning public health systems, and not only for new trainees, but for our existing employees. So think about that as we get into the question period. And so our next speaker is Dr. Gerlin Gedig. We're going to hear from her on the process undertaken by the WHO's Eastern Mediterranean region to work with ministries of health and the IANPHIs to build consensus on the essential public health functions. Over to you, Dr. Gedig.
I think Gulin is joining. There you are, yeah. I think you're on mute, Gulin, or? Have we got volume? Gulin, you're muted. We can't hear you at the moment, Gulin. Just a minute. Can you try again speaking? Oh, they can hear online. It's just in the room. Yeah. Can you speak again, Gulin? Yep. So at the back there, can you click the unmute button? Just have we got the volume now? Is someone at the back able to say what's going on? Oh, Gulin, it says you're still muted on your screen. But Gulin, I think we're going to pause it for now because we can't get this working, and if we move on to the next one, yeah.
We all need to be scalable and flexible. This is part of it. So I think we move on to Dr. Raji Tajuddin, who is going to be speaking about the work being done by the Africa CDC to promote MPHIs and supporting the strengthening of MPHIs and emergency workforce capacity in the region.
Good afternoon, colleagues, ladies and gentlemen. So I will take you through MPHIs and what we're doing as Africa CDC in terms of emergency workforce capacity building on the continent. All right, so I know Neil has one of, so let me try to imitate Kasum. Okay. All right, so this is the Africa CDC operating model. You can see the headquarters, you can see regional coordinating centers, and you can see the National Public Health Institute that serve as entry point for what we do in terms of supporting our member states. Again, this is the Africa CDC House, which is just a snapshot of our strategic plan. And if you look at the priority number 4, is about strengthening National Public Health Institute. And if you look at those cross-cutting enablers down there, you will see that supporting health workforce development on the continent is a cross-cutting enabler for all the 6 strategic priorities you're seeing on the screen. Again, this is where we were when we came on board in 2017 in terms of our MPHI. And today, this is where we are on the right side. So when we started off as Africa CDC, there were 14 member states with a fully established MPHI. Today, we can say that we have 53 of our member states with our MPHI. Much more importantly, when we came on board, there were 23 member states without any form of MPHI. Today, that number has gone down significantly to just 13. So these some of the tools we developed. I'm sure you can recognize some of our colleagues are in here. So this was back then when Africa Union, together with the Ethiopia Public Health Institute, hosted IANPHI. So again, these were some of the tools that were launched at that particular meeting. MPHI development framework, the legal framework, monitoring scorecard, One Health, and the public health workforce development. So in terms of what we continue to do to support our member states, we have the peer-to-peer and the training program, whereby we mobilize MPHIs who are not so developed to go to those MPHI that have that expertise, to support in terms of exchange of ideas, in terms of sharing best practices. And in 2023 alone, we were able to support 19 MPHIs, to visit the other MPHIs who are supposed to be fully or well developed. So usually, as part of networking of our MPHI, we do have two meetings in the year. So we have the mid-year meeting, which is mainly for regional convening of MPHI. And this is framed around our regional coordinating centers and the regional economic communities. Because those regional economic communities also have what we call the regional health organization. So as you can see on the screen there, so we have the regional meeting and we have the annual meeting, which usually take place on the margin of the Conference of Public Health in Africa. So I'm sure you can see some colleagues on the left downward side of your screen. Crucially, you can see that these days we are working closely with WHO to move the MPHI agenda forward. So in terms of workforce capacity, what exactly are we doing? So as you can see on the screen there, and just as my previous panelists do mention, we need to strengthen leadership. And 4 years ago, we launched the Kofi Annan Global Health Leadership Program. So today, we have trained 39. We have 20 fellows currently undergoing training. And come was it April, so we'll all be in Rabat, Morocco, as part of the training for this Global Health Leadership fellows from our MPHI. Number 2 is around support for our member states in terms of the field epidemiology training program. Today, most of the field epidemiology training program are actually suffering. And as Africa CDC, we decided to support 2 regions, the Central Africa and the Southern Africa member state. So currently, we have 63 fellows undergoing training. To strengthen the primary health care, we are also supporting the frontline field epidemiology training program. So currently, we have member states in the Central African region benefiting from this support. We're also working our member states in terms of using burden of disease estimate to inform policy and practice. So we're working with Institute of Health Metrics and Evaluation to do that. And we've supported 49 member states as far as that capacity is concerned. And last but not the least, on the screen there, you will see that we're also supporting the nurses and midwives, because you cannot continue to talk of health security when the nurses are left behind. So in this regard, we're working with the Harvard School of Public Health to train our nurses on their leadership. And we have the second cohort currently undergoing training. So in terms of research, we're supporting our member state to build their research capacity. Now, let me shift gear and go to emergency workforce capacity. Let me start by saying that on the margin of World Health Assembly in 2023 in Geneva, together with WHO, AFRO, and EMRO, we launched the Joint Emergency Action Plan, to support our member states in terms of building emergency workforce and putting in place a very robust resilient system to tackle emergencies. As you can see on the screen, so those are the objectives of that particular collaboration with WHO. So as Africa CDC, in order to support the workforce gap on the continent, we launched what we call the African Epidemic Services. Let me use this opportunity to thank partners in the room, from USCDC to RKI to MasterCard Foundation to CEDA to Swedish Public Health Agency, who have actually supported us in terms of moving this agenda forward. So this African Epidemic Services is modeled after the European Program on Intervention Epidemiology and the US ERS program. So today we have 3 tracks as far as this is concerned. We have the Applied Epidemiology, Lab Leadership, and Health Informatics. So in terms of emergency workforce capacity, as you can see on the screen, we are building capacity around legal instruments to support public health emergencies. We are supporting our member state capacity in terms of public health emergency operation centers. We are also continue to strengthen and scale up the African Volunteer Health Corps. Currently, we only have this at the headquarters, but we are moving ahead to establish the same thing we have at the headquarters, at the regions, and at the national level. So that when there's any outbreak, before it becomes epidemic or pandemic, the national rapid response team is able to respond. If they overwhelm, they get to the regional level. If they get overwhelmed before they get to us in Addis Ababa. So this is what we're doing in terms of that. Currently, we have 1,000 rapid responders in the roster, and we'll be scaling that up to 2,000. And of course, knowledge management, especially when it comes to research during a disease outbreak. Again, this is Joint Emergency Preparedness and Response Action Plan that is jointly, launched by WHO and Africa CDC. And you can see the different areas of focus, and you also see on the right-hand side of your screen the target for 2023 to 2027. But much more importantly, we want to build a network of emergency health experts, expand our roster, and also include emergency medical teams. We want to support 21 member states to establish and operationalize public health emergency operation center, and the rest, as you can see on the screen there. So colleagues, ladies and gentlemen, these are some of the priority areas. And let me stop here, and I'm more than glad to answer some of your questions. Thank you.
Thank you so much. Dr. Taj. Next, we're going to move from that incredible overview of the Africa region in terms of building capacity to the European region. We're going to have Dr. Anders Tegmo and Dr. Diana Van Dale to give us an update on the EU Team Europe initiative on strengthening the NPHIs. Thank you.
Good morning to everybody. And it's a great pleasure for me to be here with you today. And many thanks also to IANPHI for organizing this very important event. So I'm just going to give a small introduction to the Team Europe initiative on support to public health institutes in Africa. And Anders will then go more into detail of the TEI, what we call Team Europe initiative. We shorten TEI. On support to public health institutes. So the Team Europe initiative on support to public health was set up in the framework, in the context of the Global Gateway in a package that was presented at the 6th EU-AU Summit, where we presented this Global Gateway package that is composed of 4 flagships. The first flagship was a short-term flagship during COVID, supporting supply of vaccines and rollout. A second flagship, which is already running, is the support to manufacturing and access to vaccines, health products, and technology in Africa. And then we have flagship 3, where we have actually 3 Team Europe initiatives, where I will come back to. So which are focusing on strengthening health systems in Africa, capacity for pandemic preparedness, digital health, and public health. A 4th flagship is focusing on enabling the environment to support sexual and reproductive health in sub-Saharan Africa. Next one, here you see the flagship 3, which is composed of 3 Team Europe initiatives. Because there's sometimes some confusion, like what is the European Commission funding and what is the Team Europe initiative. The Team Europe initiative is actually bringing together what the Commission is funding in programs, but also what the whole member states of the European Commission are doing. So we have in this flagship bilateral country support, which is already going on for some time. And now we have the regional Team Europe initiatives. We have one regional Team Europe initiative on health security using a One Health support approach. We have the Team Europe initiative on public health, supporting public health institutes, on which Anders will tell you more. And we have the Team Europe initiative on strengthening digital health systems. We are scheduling the launch of the 3 Team Europe initiatives during Belgian organized under the Belgian presidency of the European Commission. End of March, we will launch the 3 TEIs. Now, this flagship is specifically answering to the African Union call for a new public health order. And we are also supporting specifically Africa CDC to support the implementation of its mandated to support national African public health institutes. So I will now hand over to Anders.
Thanks, and very nice to be here and present an initiative that's really focused on you, the public health institutes. I mean, we often hear that you're troubled by having many donors on vertical programs, and we hope that this can work in a more horizontal manner and give support to that, which is not so common. And what we are hoping to do with this is to really support the core functions as defined by WHO and African CDC and many others, but also to establish better collaboration and work on what Touch already mentioned. How can we form these networks, both here in south to south, but not least from Europe to your countries, and become a more coherent partner in that. And of course, I mean, there are many reasons why we should have a regional work, and the pandemic has really taught us how important it is to work on a regional level. There are a number of problems that we can work on that. And before Neil stops me, I'm not going to go into any details here, so you're going to have to look at the slides afterwards and see the details of this. But of course, there are also many very important added values on working on a regional level, and African CDC is, I think, a clear sign of that, both to become more coherent, but not least in that become more efficient when it comes to capacity building. So, of course, this program we're talking about will be very closely aligned with African CDC's work, and we will also be very closely aligned with the other Team Europe initiatives, so we don't overlap and that we really keep close what we do in the different parts of the system. But in the end, what we want to achieve is, of course, a more resilient, a stronger health system in all of these countries. And the conceptual framework, of course, goes back to what African CDC has already been presenting here, so I don't need to go into any details on that. And I think this is very interesting, because when we start putting together what Europe is doing in Africa and doing together with Africa, we can see that actually we are reaching most countries in Africa. It's only a couple of white spots, which I think is quite interesting and I think really promising for the future to work together, that we can really cover everything. And then in this specific project, we will mostly focus on 10 different countries, which are the ones on the right side. And these are the European members of this Team Europe initiatives. Of course, there's a number of other European countries, but we believe that these are the ones that covers most of the activities here together with you. So where are we today? We, first of all, really to become better in Europe in becoming coordinated, because for our sake, but not least for your sake, that we can work together better in a way so we don't overlap and we don't really see the gaps that we need to fill. And then now we are starting a collaboration with African CDC and IANPHI to see what activities can we do to fill the gaps that are still there in different ways. And then after the launch that Diana started, we can start doing this for real. So, thank you.
Thank you very much. Next, we're going to hear a country perspective. We're going to have Dr. Natalie Mayet, who's going to describe South Africa's experience and of planned reforms of the public health system and the need for building epidemiology capacity with reference to the work of the Global Financial Education Program. Thank you.
Thanks, Dr. Tam. So I've taken the advice of Neil and not to do a PowerPoint presentation, risk mitigation, but I'd like to share the story of supply and demand. We started our field epidemiology training program in 2006. And it was a collaboration already then with the Ministry of Health, academia, our US colleagues in terms of seed funding for the program, and the National Institute of Communicable Disease, the Public Health Institute in South Africa. We had laboratory training program there initially, but we dropped that very shortly after the inception of the program because we were cannibalizing on very limited laboratory capacity into the program. So the goal of this program was to enhance the capacity to strengthen health systems, to detect, to respond, and to prevent public health threats through competency-based learning and training through service. And that's very, very important components which were mentioned by our panel. But the service aspect is something that we underplay in our experiential learning. And that's something that I think is a challenge that we need to take forward, is how do we build in that service component? Because it's learning by giving, learning by doing. But in adopting that model, you require strong mentorship. And mentorship capacity is something that we're going to have to build as part of developing the future public health care workforce. So this program is delivered through 3 tiers, through a 2-year full-time competency-based learning program in partnership with academia, but it also provides in-service training for the healthcare service through the frontline training program and intermediate training program. We need to start building disease intelligence through our healthcare system. When we recruit for our for our 2-year training competency program, 25% of the professionals applying for the program fail on a basic numeracy entrance eligibility test. 25%. So we've got to build disease intelligence for surveillance in our healthcare system. And how do we do that? We do it through training on the ground, through case studies, through experiential learning, through changing policy at grassroots level by using surveillance data. Unfortunately, our yearly intake ranges between 10 to 15 people on an annual basis. So we've trained 131 field epidemiologists since inception of the program, but in the country, based on WHO norms, we need 350 epidemiologists. And Dr. Taj will tell you, in Africa, this is a shortage just of this one cadre of field epidemiology. So the advantage of this program, it's interdisciplinary and multidisciplinary. We have veterinarians on the program, we have nutritionists, we have social scientists, we have nurses. We cannot attract medical doctors into the program. For some reason, unlike Zimbabwe, Zimbabwe has attracted medical doctors, and a Zimbabwean medical doctor heads up our field epidemiology training program, but we cannot attract them. So why? What are we doing wrong in not allowing our medical doctors? And I think this is something that we need to grapple with as we move forward. So the program is funded. It was initially funded with seed funding from US CDC. And the pendulum swung that we funded it through government. And the pendulum has swung post-pandemic back to the reliance on donor funding. What are we doing wrong? Post-pandemic, governments should recognize you've got to fund these kind of programs. And in the pandemic, everybody asked, where are the epidemiologists? They were the first responders. They were at midnight collecting samples from the first patients. They were doing the contact tracing. So the value of the epidemiologists were recognized during the pandemic. And we've got to do a stronger job of demonstrating the value that this cadre, just one cadre, brings to the healthcare services. There was a human resource strategy developed in the country for the workforce for universal healthcare coverage. It does not mention public health, and it does not mention epidemiology. And I think the limitation of this is recognized in the 5 goals that this strategy has articulated. The first goal is to plan ahead. Look at your current needs, but identify the future needs. And so in crafting our future healthcare human resource strategy, we've got to identify what is the cadres required for our future healthcare workforce. And what we must not forget is the back-end cadre required. Medical technologists who are required to put in the pipe of the ventilator when it comes out during a pandemic, medical technicians, laboratory technicians and technologists, the IT professionals, the procurement officers, and we forget that these are all elements and cadres that are essential for pandemic preparedness and response and for turning the wheels and the engines of our healthcare workforce. So the second goal is having a data-driven healthcare workforce policy. So setting up the electronic database, setting up a consultative workforce forum to drive and understand, interpret where there's surge capacity required. The third goal is the competent and multidisciplinary healthcare workforce, as has been mentioned. Goal 4 is optimal governance and leadership, accountable for management, deployment, ensuring that there's a motivated healthcare workforce, which is goal 5 in terms of gender equity, occupational health and safety. This plan has articulated multiple subsections, and I think this is where we're going to reach. But the challenges that we face, credentialing of our healthcare workforce. Our Health Professionals Council in South Africa cannot credential interdisciplinary and multidisciplinary cadre. And I think this is something that we need to work towards. Who drives the workforce strategy in the country? Is it the NPHI? Is it the Ministry of Health? Or is it us collectively? So in terms of collaboration, let us not forget the private sector and the NGOs and the CBOs and the faith-based organizations who provide key elements in our healthcare workforce strategy. So if we are going to achieve universal healthcare coverage, if we're going to be prepared for the next pandemic, if we're going to deal with the colliding syndemics, if we're going to deal with the next new public health order, we need competency-based education. We need interprofessional education grounded in large-scale information technology and health economics, where we have healthcare professionals who are science diplomats, who are cared for and who care and who can influence. If we're going to do that, we need to make our healthcare professional and public healthcare workforce attractive, and we need to demonstrate the value they add through recognition and through the multiple partnerships that we face in terms of global initiatives like IANPHI, the Global Public Health Workforce in Epidemiology, TEFINET, Africa CDC, and our collaboration. Thank you.
Thank you. Thank you so much. That was an incredible account of your experience. And I think you also mentioned, what exactly is the role of the MPHIs in inputting into a health workforce strategy? Can you get your foot in the door and make sure that it's, the public health aspects of the health system is well taken care of from a workforce perspective? So we are going to try and go back now to Dr. Geddick on screen. Back to the Eastern Mediterranean region.
Can you hear me now?
Yes, we can hear you.
Oh, perfect. Great. I'm trying to share my screen. First of all, I would like to thank you very much for the organizers for inviting me, and I'm very sorry that I couldn't be in person there, but I'm very glad at least I can join this way, and thank you for your patience for my technical issues faced. So, I think quite a lot has already been said, and that makes my presentation much easier because I don't need to repeat what have already been said and very well articulated. a brief history from the perspective of Eastern Mediterranean region. So, as we have seen, many regions, countries have looked at essential public health functions, developed their essential public health functions at different times in the past. And in the Eastern Mediterranean region, this process was initiated a decade ago. And actually this was triggered with the request of the Ministries of Health in terms of identifying the roles of different public health institutions, functions, and how to provide the services which are public goods. So, essential public health functions framework was developed, and then it was tested with an assessment tool in a number of countries, working very closely with the Ministries of Health. And then the world faced the COVID-19 pandemic. And that also highlighted the importance of robust public health systems, and also that gave us the opportunity to review the Eastern Mediterranean region essential public health functions with the lessons learned from COVID-19, as well as our previous consultations and work together with the Ministries of Health. And then we were able to review and revise our essential public health functions based on the regional and country context in our region. And throughout this work, also we have worked very closely with the UK Health Security Agency, Dr. Neil and his team. And with the renewed framework, the Eastern Mediterranean region essential public health functions framework identified 5 core functions, which includes health protection, surveillance, public health services, health promotion, and disasters and emergencies. And in addition to the 5 core functions, 4 enabling functions have been defined, which includes governance, workforce, research, and communication. And of course, some sub-functions were detailed for each of these functions. For the sake of time, I will not go through all these functions, but I will just highlight as an example 2 enabling functions which are really critical in taking forward this agenda. First, I will have a little bit give a glimpse on the governance function. 4 main sub-functions have been identified in terms of governance function to be able to take this agenda forward. And it emphasizes the legal, legislative basis, required institutional arrangement, and financing. And also governance emphasized the multi-sectorial aspect of the implementation of essential public health functions, which has already been emphasized by other countries, which goes even beyond the health sector and other sectors. So the governance function has been elaborated in that area. And then the question comes, who will deliver the essential public health functions? What are the competencies required in the health workforce, and what are the cadre's needs? And already my dear colleague Hassoum has mentioned the broad range of cadres, types of health workforce involved in the delivery of essential public health functions. And I think what are the competencies we need for that? And again, together with UK Health Security Agency, competency framework for the Eastern Mediterranean region has been identified based on our context. And this framework can be useful in many ways. It can help us to guide the workforce planning, develop the job descriptions with the required skills and experiences, to assess the current capacities, and also this can serve as a guidance for competency-based education and training at different levels of the education training, including undergraduate, postgraduate, and continuous professional development. So, I think as a conclusion, the public health challenges experienced during the pandemic have highlighted the importance of resilient health systems with a renewed interest in public health capacity. And in our regional committee in 22, the regional committee adopted a resolution on building resilient health systems, which identified 7 priorities. And focus on essential public health functions, and also building public health capacities of public health institutions have been among the identified priorities for our region. And in taking this further forward, in 23, the year after, and a few months ago, in October 23, our regional committee adopted another resolution on health workforce, which calls for action to accelerate the implementation of health workforce strategies and priority action, and which also emphasize the focus on health workforce for essential public health functions and emergency response, and with a special focus on the public health professionals. As Hassan mentioned, they are also very important and core, this, together with other health workforce involved in the delivery of essential public health functions. And essential public health functions really provide an integrated, sustainable framework for countries to strengthen their public health services, and this framework is continuously being discussed, consulted with the member states in the countries, and member states are using the framework in guiding their overall health policies, health workforce policies, and strengthening the public health institutions, including which includes the National Public Health Institute. So thank you very much, and thank you for this opportunity. It's back to you.
Thank you. So we've heard from all of our panelists, which gave us a lot of food for thought. And maybe I'm going to hand over to Neil to try and facilitate the Q&As. There, I think, will be a microphone that will be passed around, or Neil can hand one to you.
Yeah. So we've heard from the globally, regionally, and nationally. But as national public health institutions, you have the responsibility of ensuring that you've got the capability and the workforce. So I'd be really interested just to have some short examples from countries of issues they've faced in developing that, or comments or questions to any of the presenters. So let's get the energy levels up. I'm looking for hands now, people looking to engage. So Duncan.
So mine is more of a comment. I mean, I absolutely love every time I listen to Taj about what's going on in Africa and the role of the CDC. And it's, I mean, quite honestly, if this was imaginable 7 years ago, it's so inspiring. And please take that back. And this work with the European initiative and how that amplifies and supports, but it's not in replacement of or because Africa itself is not steaming ahead in these areas. It's an example to the world. to Natalie and about the workforce, without a workforce, we have no strategy. There is no strategy that is capable of implementation without the people. And if I'm thinking about my hospital years, we talk about doctors and nurses, but it's not doctors and nurses that make hospitals work. It's all the people you don't see that make sure that you can do your major surgery and that keeps frankly, including the payroll and all the folks that, are not visible. And we need to think, as you set out there, what does this mean for the public health workforce? Because we learnt that through the pandemic. And this initiative is so important that we can get this competency-based understanding of this widest appreciation of what it means to be part of a public health workforce. So I just wanted to say I am overwhelmed by the interdependencies of Sohol's work on the essential public health functions, the team, the global team, Jim and the team's effort on the workforce, and what we'll be discussing over the next day or two on emergency response and how we do that better as well. So it was just, I'm afraid, an opening comment I was very keen to make.
Thank you. Well, I'm going to, excellent, yes.
Thank you. From Brazil, Fiocruz. I would like to congratulate all panelists, and I would like to launch the questions about, of course, we need to train our professionals for all levels, but my problem is how we will deploy our human resources, how we will pay them. Once we know that the Minister of Health is very weak financially, and who is the powerful Minister of Finance in the countries that are the real power. In Brazil, for example, our Minister of Health is the first, after Minister of Finance, with the biggest budget in the government. But I think that in this panel, we lack World Bank that talk about fiscal problems in the country. I would like you to comment on that. This is the first thing. The second thing, we should look for the constitutions in the countries. The constitution is very clear about health expenditure or not. So I'll leave you with these questions.
Thank you. Did anyone want to comment on the financing, which is a critical issue for the workforce? But I was also just going, whilst you're thinking about that, then I was going to ask Ethiopia, because we had a conversation last night when you mentioned the training of the field epidemiology, and I just wondered whether there's anything from the country perspective that you'd like to add on the workforce and the work that you've been doing.
I'm not specifically prepared for this, actually. But in Ethiopia, actually, the field epidemiology workforce training, particularly the short-term training, the frontline health workforce with the first responders training, often has been undertaken by the Ethiopian Public Health Institute, the National Public Health Institute, is responsible for training, deploying, as well as monitoring the cell workforce in deploying in different parts of the country wherever the outbreak or disease epidemics occur. In terms of sustainability and many other issues, we work closely with the Minister of Health. A lot have been said about the accreditation, the competency, and many other things, usually managed by the Minister of Health, but we closely work with the Minister of Health. But when it comes to deploying various health workers in different parts of the country with different sectors, it is the first responsible body, the Ethiopian Public Health Institute, to collaborate, coordinate, as well as manage those health workforce, but there is no clear line of responsibility and accountability in terms of training and accreditation. But still we collaborate with the Ministry of Health and respond to various public health emergencies, even involving other sectors when it comes to public health emergency management. Otherwise, the sustainability, the financing, and many other issues should be the assignment for not only for the National Public Health Institutes, but for the Ministry of Health and other sectors, including the Ministry of Finance, the body that always decides on the financing, the budgetary issues, and the like. Thank you very much.
Thank you. And Kasum, you're going to come back on the financing, I think. Yeah.
Hello. Yeah, go ahead. I can go ahead? Oh, thank you. I'll stand since I'm sitting in the dark. Thank you. I'm Dr. Chirenda from University of Zimbabwe. So I would want to make a comment in response to Natalie's presentation. When we started training field epidemiologists in 1993, I think, we had the same problem of not attracting clinicians for almost 10 years. And then we made an intentional decision to go around the country to explain why clinicians should come and train as field epidemiologists. Now we have it's actually oversubscribed. So I don't know what trick we did, but that's what is happening. In terms of health workforce development for field epidemiology, it's in Zimbabwe is very clear. The University of Zimbabwe and other academic institutions have responsibility in training or developing health workforce, from nurses, doctors, pharmacists, and of course the actual field epidemiologists at master's level. The Ministry of Health responsibility is to guide. It's a joint program. We have an office sitting in the Ministry of Health, a university office. We have joint planning meetings where we say, these are the cadres that we want trained in field epidemiology. And our responsibility to train, that it will address the sustainability issue that my colleague from Ethiopia was referring to. Ministry of Health is also responsible for mainly outbreak response and surveillance. Issues of research and everything are responsibility of academic institutions. That way it makes it very clear and avoids issues of TIF. So I thought I could comment on that. Thank you.
Okay, thank you very much. The name is Tunde Salako from Lagos, Nigeria. My question is to Natalie, especially that we're paying attention to workforce that have not been recognized in the past years. She mentioned finance, procurement, and things like that. And most of the time when we define workforce, we don't remember these people. So I wanted to know your opinion about expanding that definition such that in future, when we're training people, we do not just limit it to the medical professionals, because these people play an important role when it comes to financing, making funds available, especially during emergency and response to emergency. And many of them don't understand the dimensions of what the professionals are doing. So they keep quoting some of their laws that restrict fast access to funding. And I believe that if that cohort of people are part of the definition and they now understand the processes and what is required in such emergency conditions, that release of fund procurement processes will be fastened.
I think we have just one final comment from the floor, Andrea.
Yeah, thank you. Andrea Amon from the ECDC. I think the issue with the health workforce has a zillion layers and facets. And I think it's impossible to address all of them. But I think we all have, I at least have made the same experience as Natalie, when everybody says, oh, the health workforce is in a bad shape, they're running away, it's not attractive. Nobody talks about public health, which is usually even worse. So we have to advocate this because nobody does it if we don't do that. To make sure that when there are health strategies, workforce strategies taken up, that public health is considered. One thing. The other part is we have to the diminishing public health workforce, attract people to take it up. And that is the next issue where there are conditions that they work under that we cannot change. So it's another area where we have to actually do advocacy, that the working conditions, the salary conditions, the career perspectives, work-life balance, and so forth is changed. Now, then it comes to the training. And there, what you have said is also what we experience, that our epidemiology program that we offer is very thorough. It turns out really good experts, but it takes long, and it doesn't meet the immediate need. So we also have to diversify to address those that are already in service, to address those, if, for instance, for the Volunteer Health Corps or our EU Health Task Force that we are now building, that they also get training and sort of ensure an upskilling of those that are already in service or that we use for certain occasions. So I think there are a few things where we can directly influence, and there are other things where we have to do advocacy because it's at least outside of our control.
Thank you very much. And unfortunately, I think I saw a few other hands up, and we don't have time because you're all hungry, I think. I think the key is to network and partner and sort of look, you know, we've got 1.5 more days of this really quite incredible opportunity to do that. I will have to say that as national public health institutes, we have to actually tell our decision makers who works in public health. What is public health? You know, there's functions. Who exactly works in it? They have no idea. And there are many people, as Neil has said, and Neil and Duncan and others have said, how do you describe it to someone in order to say, well, what resources you need and what, you know, I think that's actually something that we can all learn from each other on, to make that case and to insert ourselves at the table when people are talking about the health workforce in general. So I think we should all give a round of applause to all of our panelists, both virtually and on the platform. Thank you so much for sharing your experience.
So, yeah, I don't think we need to answer any of the questions. There's lots of time to have discussions in between, and I don't want to keep people from their lunch. So we pick up, please, individually with the speakers if you have questions of them, then we can have a discussion over lunch. So thank you, everyone. Look
Hello everyone, if you could take your voucher and go to the restaurant room where we had breakfast, that's correct. This is the only place where we can all fit in, so yeah. So, and we will come back in 1 hour time. Hello again. We were told that if you wish, you can leave your bags in the room.